All right, welcome back. Thank you for joining us today. We are thrilled to have Dr. Bansal here to conclude our seminar today to talk about the importance of the heart in neuromuscular disease. Dr. Bansal is an attending physician in the Department of Pediatrics at Children's Hospital of Montefiore and an assistant professor of pediatrics at the Albert Einstein College of Medicine. Her clinical focus is pediatric patients who have heart failure due to cardiomyopathy or congenital heart disease, as well as pediatric transplant patients. She is also interested in echocardiology in her setting of heart failure, as well as cardiac care of survivors of childhood cancer. She is a member of numerous professional societies, including the American Society of Echocardiology, the International Society of Heart and Lung Transplantations, and the American Heart Association. So with that, Dr. Bansal, I'd like to turn the presentation over to you.
Great. Thank you so much for having me. Thank you so much, Dr. Delfiner, for working with the MDA. And thank you, MDA, for this wonderful session for all our families and all the patients out there. So my topic, and it's bad that I'm going last, so I hope you guys have some energy for this last 1 hour. So the heart is also a muscle. The cardio complications are a very important part of neuromuscular disorders, and I'm grateful to be working with an amazing team, part of whom you've heard before today. So today we're going to talk about what are the different types of cardiac complications, the two most important ones being the cardiomyopathy as well as conduction abnormalities. We're going to talk about the testing and the surveillance of these cardiac complications. We're then going to be talking about the management. How do we manage all these cardiac complications? We're going to be talking about medical management, surgical management, and that is the outline of my talk today. So first, talking about the types of cardiac complications. So cardiac complications in neuromuscular disorder, as we all know and have heard today, neuromuscular disorders are a broad spectrum of diagnoses. They have very overlapping but distinct phenotypes. You have some phenotypes that have cardiac complications that are more, where the heart is more involved and is more severe, and especially when those symptoms of neuromuscular diseases appear in childhood, or the patients show a very rapid progression during infancy. And in some cases, or in most cases, the progression or the onset of this cardiac involvement are dissociated from or occur later than the development of the skeletal myopathy. There is not very good correlation between the genotype and the phenotype of the cardiac and the skeletal muscle level. So your heart is also a muscle, and your skeletal muscle. So there is not very good correlation. If your heart is weaker, then your skeletal muscles are weak, or if your skeletal muscles are weaker, your heart is going to be weak. This is why we like to do surveillance. This is why we like to screen all the patients. One does not predict the other. Clinically relevant cardiac involvement most commonly falls in two categories, one being cardiomyopathy and the other one being conduction defects or arrhythmias. So talking about cardiomyopathies first. So cardiomyopathy, cardio comes from, means heart, myo means muscles, pathy means disease. So very simply put, it's the disease of the heart muscle. So most commonly in patients with Duchenne or Becker muscular dystrophy, we see something called dilated cardiomyopathy. So where the heart becomes big and dilated. We do see some abnormal dystrophin protein in these patients, and the myocytes become, or the heart muscle tissue becomes very disrupted, and that results in the dilated cardiomyopathy. This can be very variable in age of onset or in its severity. Some patients have very mild dysfunction, and some patients have very bad dilated cardiomyopathy, very severe form of it. Most recent studies suggest that average age of development of abnormal cardiac function in Duchenne and Becker muscular dystrophy is around 14 years of age. Now, talking about limb girdle muscular dystrophy, we also see cardiomyopathy occasionally in these patients, and they can be either dilated form or another form of cardiomyopathy known as hypertrophic cardiomyopathy, which means that the heart becomes thick and results in poor function because of the thickness of the heart. Because even though you have more muscle, the muscle itself is not good muscle and it doesn't squeeze very well. So the common symptoms of heart failure or cardiomyopathy are shortness of breath, fatigue, activity intolerance. Doc, I was not able to climb the flight of stairs that I used to. I couldn't do my grocery shopping anymore. Or there's loss of appetite that we often see in teenager patients. However, patients with neuromuscular disorders are unique because they have problems with their skeletal muscle disease. So when they say that they have shortness of breath or activity intolerance, or they're not able to walk as long, or they get tired very easily, it is very unclear whether that is because of their heart function or whether that is because of their skeletal muscle weakness. So that is why you can sometimes have cardiac dysfunction or the squeeze of your heart. You can have bad heart function without even knowing it, because most of the times the weakness or some of these symptoms are attributed to the patient's muscle weakness and not so much the heart failure. So this is why it is very important for us to have a cardiac evaluation of these patients on a regular basis so that we can detect the cardiac dysfunction early on. And the only way to detect the decreased cardiac function, it is detected by echocardiography, echocardiogram, or an MRI. So this is here an example. I wanted to show you some clips. This is an example of a patient with very good heart function. You can see the two lower chambers of the heart. The one that looks like a donut is your left ventricle. The one that sits on top of it and looks like a croissant is your right ventricle. And you can see that both the chambers are squeezing very well. The heart function is normal. This is what we call a four-chamber view of the heart. This is a picture that is very easily understandable by most parents. So the heart has four chambers, two upper chambers, two lower chambers. And here you can see that the two lower chambers, which are our main pumping chambers, are squeezing very well. And this is somebody with a normal heart function. Now let's look at somebody who has dilated cardiomyopathy. So this is a patient who has dilated cardiomyopathy. As you can see, again, you have the chamber that looks like a donut, and on top of that, the chamber that looks like a croissant, your left and right ventricles. And you can see that this heart is really blown up. It looks very taut. The muscles are not squeezing. It's not coming together. It is just sitting and rocking there. This is a heart that is very, very weak, does not squeeze very well, and this is an example of dilated cardiomyopathy. Now let's look at the four-chamber view of this patient. So once again, think about what you saw before. These are the four chambers of the heart, and you can see over here that both the bottom chambers, which are the main pumping chambers of the heart, are not squeezing very well. They are just sitting there and rocking. This is the problem in dilated cardiomyopathy. The muscle itself has become very weak, and it's unable to pump that blood all the way to the rest of the body. And the body is unable to get enough blood. And this is the main problem in patients who have dilated cardiomyopathy and heart failure. Now let's look at somebody who has something called a hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, as I was telling you, means that the patient has extra muscle. The muscle becomes thick. So again, these are the two ventricles. You can barely see the ventricle that is up on top, the one that looks like a croissant, the right ventricle. You can barely even see the cavity in it because the heart muscle in itself has become so thick. And as you can appreciate here, compare it to the absolute first picture you saw, you can see that the squeeze of the heart, the function of the heart, is not really robust. It is squeezing, yes, it is better than the patient that we saw right before, but it is still not absolutely perfect. It is because the thickened heart muscle becomes very inefficient. It does not squeeze very well. More muscle does not mean that it's better. More muscle just means that there is a lot of what we call myocardial disarray, that the myocardium is very inefficient. It is unable to squeeze very well. And this also becomes a problem because the patients are not able to get enough blood because the heart is unable to relax. The heart is unable to fill. And when it's unable to fill, it's unable to eject very appropriately. And this is again just a 4-chamber view of that same heart. As you can see over here, that the heart, the walls of the heart have become very thick. They have become very, especially the lateral side or the side on the sides, you can see that the heart, the muscle itself is very, very thick. So this is an example of hypertrophic cardiomyopathy, where the heart becomes extremely thick. So these are the two types of cardiomyopathies that we sometimes see in patients with neuromuscular disorders. We can see either a dilated cardiomyopathy, where the heart becomes really, really big and taut and unable to squeeze, or we see something called hypertrophic cardiomyopathy, where the heart becomes thick, it becomes inefficient, and the heart doesn't squeeze very well. Now, the second type of abnormality that we see is something called conduction abnormalities. So this is the conduction system of the heart. As you can see over here, you have the heart, the blood vessels, and the red and the blue. And the dark blue is actually the conduction system of the heart. You have something called the sinoatrial node, or the SA node, that sits in the right upper chamber of the heart. That is your inherent pacemaker. This is a node that that is the inherent pacemaker. So it drives the heart rate, how the heart beats. That is where it all comes from. The sinoatrial node, once it triggers a heartbeat or a conduction, it travels down the upper chambers of the heart and then slowly gets spread to the two lower chambers of the heart, what we call by the two bundles. So one is a right side bundle, left side bundle, and both those bundles go to different parts of the ventricle, the two lower chambers or the pumping chambers of the heart, and forces the heart to squeeze in a very symmetric fashion. So you have the top chambers of the heart squeeze first. They pump all the blood to the lower chambers of the heart, which are the true pumping chambers. And once the pumping chambers get the signal, they squeeze and they pump the blood out to the blood vessels. It is a very complex mechanism and works very beautifully when it does. So sometimes we see in patients with complications, we see cardiac complications in this conduction system, so the wiring of the heart. We see that in patients with limb-girdle muscular dystrophy, you can have atrial, which is the upper chambers of the heart, or the ventricle, which is the lower chambers of the heart. You can have something called heart block, where the upper chambers of the heart and the lower chambers of the heart don't really talk to each other anymore. You have patients with Emery-Dreifuss muscular dystrophy. Sometimes you can have progressive abnormalities throughout the course of the lifetime that result in heart block or sudden death. Patients with myotonic dystrophy, which is, we see conduction abnormalities pretty commonly, almost 80% when you have type 1 myotonic dystrophy. we see patients with conduction defects. So the upper chambers of the heart and the lower chambers of the heart don't really talk to each other, and they're pumping at their own rate, separate rates, which results in sometimes not enough blood being pumped to the body because they're just beating at their own rates, and they're not really talking to each other. This is an example of EKGs. So EKGs are electrocardiograms that basically are those numerous leads that you might have seen we put on patients. What it does is it maps out for us how the conduction system of the heart is working. It maps out for us where the electrical signals are coming from, what chamber of the heart, and how are the top and the bottom chambers talking to each other. So let's walk through this. Over here is a normal rhythm. So what we call a normal sinus rhythm. Sinus being rhythm that comes from the sinus node. That is the top upper chambers of the heart, the right side. So you see that this tiny little blip, which we call a P wave, it was named randomly as a P wave. And then you see this big spike over here, which is the lower chambers of the heart. So this is the upper chamber of the heart. This is the lower chamber of the heart. And this tiny hump is basically the heart relaxing and coming back to its normal first resting state, okay? So you have the top chambers of the heart, the bottom chambers of the heart, and the relaxation, okay? So now let's walk through this. When you look at the first strip here, you see the top chambers of the heart are squeezing, the bottom chambers of the heart are squeezing, and the heart is relaxing. And you see the same pattern throughout the strip. You don't see any abnormality. Now, when we look at something called heart block, that means that there is some sort of dissociation between the top and the lower chambers of the heart. So first degree heart block is that there is a delay in talking between the uppers and the lower chambers of the heart. So you see that there is a long gap between the top chamber of the heart and the lower chambers of the heart. So you can see over here, you can see that the top and the lower chambers of the heart are talking to each other very quickly, very nicely. But in the lower one, you can see that there's a delay. And as you go further, you can start to see that the top chambers of the heart are not really talking to the bottom chambers of the heart. The top chambers of the heart, these tiny spikes here, are just squeezing randomly. And the bottom chambers of the heart also looks a little different. It looks much wider, and they're not really talking to each other. So this is what we call a third degree heart block. Heart block means that the top chambers of the heart and the lower chambers, the atria and the ventricle, don't really talk to each other. Now what happens is that if the atria are beating at another rate and the ventricles are beating at another rate, and they're not really interacting, then the lower chambers of the heart, the ventricles, don't get enough blood to fill completely. And they're not able to eject completely. And you start to feel dizzy because your heart rate is lower and you're not getting enough blood. So you start to feel dizzy, you don't feel great. And a lot of these patients end up getting pacemakers because they're symptomatic with heart block. They're not able to walk, run, do the regular things because the lower chambers of the heart are not meant to beat at a higher rate. And they just don't keep up when you start to do exercise. You're not able to bring your heart rate up. And that is the main problem. And that is why these patients often end up getting something called a pacemaker. Now, talking about testing and surveillance, and that is the most important part of why I'm here. So there are a lot of care guidelines that exist in the literature for the diagnosis as well as management of patients with neuromuscular disorder. One of the most important things that all of them say is that the collaborating team approach results in the best outcomes. So that is why what Dr. Delfiner said, what other people have said before, that we at Montefiore have been blessed that we have a big care team where we're all able to together talk about patients, discuss patients, and give them the best tailored approach. There have been reports that a lot of the Duchenne muscular dystrophy patients, about more than 30%, which is a large number, sometimes have not even had an echocardiogram. And this is patients who are out, unfortunately, in the community, who don't have access to good MDA centers, who don't have access to complex multi-subspecialty care teams, and unfortunately don't end up getting the right care. So as I was discussing before, that you can have cardiac dysfunction in patients with neuromuscular disorders, and they can often be attributed to the skeletal muscle weakness. And a lot of the times these patients don't either get screened, either don't get echocardiograms, and we don't find out about their cardiac dysfunction till much later in life. That's why the onus is on the neurologist or other physicians who see these patients to proactively refer these patients to a cardiologist, especially a heart failure cardiologist, who can assess these patients, who can conduct an echocardiogram or a cardiac MRI, and I will go over those two tests with you, and can diagnose these patients with either conduction abnormalities with the uses of EKGs and Holter monitors. And these are all very important parts of cardiac surveillance in patients with any kinds of neuromuscular disorders. So cardiovascular imaging is, of course, as you can imagine, the most important, or it's a key role in screening and management of patients. Echocardiograms are the primary modality by which we do screening in patients. Now, unfortunately, some patients, as they slowly become wheelchair bound and have problems like scoliosis or obesity with their advancing age, the echocardiographic windows, or the acoustic windows, those are the windows through which we're able to see the heart. We have to see the heart in between the rib cage, the space in between the rib cage, and we have to penetrate through the lungs. And as you have problems and malformations of the chest, it sometimes becomes very tough to visualize the heart. So that is when you have something called cardiac MRI. So you have older patients, patients who have any sort of limitations in their acoustic windows, where we're not able to visualize the heart very well. In those patients, cardiac MRI is a better modality to do cardiac screening. So cardiac MRI is obviously, it's like an MRI machine. You go in and they're able to do a full three-dimensional anatomic analysis. So they can look at how the heart looks, how the different structures look. They can look at how the heart is squeezing. They can calculate numbers for you. They can calculate flows across different parts of the heart. But unfortunately, obviously, it has its own limitations. Number one, and the biggest one, is that it is not very easily available. MRI is a very expensive test. There are not centers everywhere that do MRI. It is very time consuming. And obviously, if you guys have seen MRI machines on TV or in movies or anywhere in life experiences, you can see that it is not a very comfortable, it's like a tiny long tube, and you sit in there for like sometimes even close to 2 hours to try to get good images. And patients who go in there who are unable to sit comfortably or lay down comfortably in a flat position, or have immobility or have contractures, those patients, it is very tough for them to be able to get an MRI. Also, if the heart rate is very, very fast, so like it is in some patients, or if you have abnormal rhythms, or if you are breathing very, very fast, that you're very uncomfortable laying flat, or young patients who just cannot remain still, patients with ADHD, those patients, the utility of doing a cardiac MRI on those patients is very, very limited, because as you can imagine, a cardiac MRI machine is very dependent on how fast your heart is beating, how fast you're breathing, and whether you can remain still, because it takes a long time for the MRI machine to acquire all those images and then spit out the numbers for you. And obviously, some of these things can be managed if you can put patients under sedation, or you can give these patients general anesthesia, and then they don't move as much, and you can control their breathing and their heart rate with the ventilator machine. You can control the heart rate by giving them medications like beta blockers. However, there are certain risks that come with sedation and anesthesia. And that is why it is not a very widely chosen test for young patients with any sort of neuromuscular problems, unless we're not able to at all visualize how their heart looks like in echocardiography. Electrocardiography, or EKGs, or electrocardiograms, they can detect abnormalities at a very early age. So you put all the stickies and we can map out how the heart's wiring system, or how the conduction system of the heart looks. We can also do something known as Holter monitors or event monitors. And some of you who are very experienced parents or experienced patients out there must have had this many times during your life. These are ambulatory electrocardiographic monitors. So you place about 3 to 4 leads on your body, and you can walk around. We normally do it for about 24 hours. We can also do it for many, many days, up to 30 days. We can also do something known as loop recorders, which are sort of these tiny Holter monitors that are put under the skin. So there are very unique ways, there are very new ways of trying to monitor a patient's EKG or the patient's conduction system. The advantage of Holter monitors or these long-term monitors is that EKG is only 10 seconds of the person's life. So there are certain drop beats or heart blocks or abnormal rhythms like tachycardias, arrhythmias, that we may not capture in just those 10 seconds that the patient is on the EKG machine. That is where the Holter monitors, or the monitors that are unique, like event monitors or loop recorders, those monitors come into picture when we have suspicion of these patients having any sort of abnormal heart rhythm. So either they can have arrhythmias or they can have heart blocks. So either of those, we try to do periodic surveillance by putting Holter monitors and trying to analyze all the beats during the 24-hour or the whatever amount of period that we do it for. So it has been advocated, and a lot of centers are doing this. It is advised by many of the guidelines or the care guidelines that are out there. So there are recommendations for testing and for surveillance that exist. They come from various different associations. So for example, the American Heart Association has care guidelines. There are some other clinical care guidelines, as Dr. Delfiner had shown you in the beginning, that have been published. So this is just an example over here of how the guidelines are phrased. So over here you can see that every 2-year cardiac evaluation by examination, EKG, and non-invasive imaging is reasonable in asymptomatic Duchenne or Becker muscular dystrophy patients who are less than 10 years of age, increasing to annual evaluation at 10 years of age. So obviously, there are certain guidelines that exist. However, if there is any suspicion, if there is any concern, the physicians can always do more screening or less screening after they talk with the multidisciplinary team, after they consult with the parents, and after they consult with the patient themselves. Sometimes teenager patients have a lot of opinions. And then again, for patients with Emery-Dreifuss, as you can see as the second point there, at least annual evaluation with echocardiogram, ECG, and ambulatory ECG, which is Holter monitor, is reasonable for patients with autosomal dominant and X-linked recessive Emery-Dreifuss muscular dystrophy. So the physicians have guidelines that exist out in the literature, and I welcome the parents to read through them. Obviously, the onus is on the physicians to read them, to give the appropriate care to the patients. However, like Dr. Delfiner was saying, it is very important that the parents take charge. They read, and they are welcome to take these guidelines to their physicians and get the appropriate testing and surveillance if they believe that they're not getting those. So now let's talk about management. So when it comes to management, there are two types of management that we can do. Medical management, which stands for medications, and surgical management, obviously, self-explanatory. So this is an example of, a guideline as to, this is by the American Heart Association. It's a scientific statement by them, that how they think that patients with neuromuscular disease who have any sort of cardiac involvement should be managed. And Dr. Delfiner showed you some other clinical care guidelines that came out recently as well. This is a group expert consensus. I do want to point that out, that the evidence that exists, or the true evidence or the true research that exists in care of these patients is very limited. As we all know, that neuromuscular disease is a very rare disease. It's a very rare disorder. So to do research that is very robust, that speaks of numbers and volumes, is very low. So a lot of these clinical care guidelines, or these scientific statements that exist, excuse me, exist because a group of these expert people who have taken care of these patients for a number of years collectively sat down and decided how we should be taking care of these patients. They decided how often they should be screened and how they should be medically and surgically managed. So talking about medical management in these patients. So ACE inhibitor is considered a first-line therapy in cardiac dysfunction. So ACE inhibitor is a type of medication that works by decreasing the blood pressure of a patient so that the heart is able to squeeze much easily. Think of your heart as your biceps, and think of the blood pressure as your weights that you are lifting. Now, if I made you lift, say, 150 pounds, your biceps will have a lot of trouble lifting those weights. So similarly, when the heart has to squeeze against a very high blood pressure, like 150 blood pressure, then the heart is having a hard time squeezing and ejecting that blood out because it is meeting a lot of resistance. Now, say if I drop that weight of 150 pounds down to 90. Now, suddenly it becomes easy for your biceps to be able to, for your muscles to be able to lift that weight, right? So similarly, if I dropped your blood pressure from 150 to say 90, it will become easier for the heart to be able to squeeze against that blood pressure. So ACE inhibitors do exactly that. They work by decreasing your blood pressure, and they remain as the first line of therapy. There are existing guidelines. There are a lot of clinical care guidelines or statements that exist that say that we should start all patients with Duchenne muscular dystrophy or Becker's muscular dystrophy who have reached the age of 10 years. We should be starting all of them on an ACE inhibitor as prophylaxis, because studies have shown that we are able to delay the onset of cardiomyopathy in those patients. So as I told you, that cardiomyopathy in Duchenne muscular dystrophy patients happens at around 14 years of age. Studies have shown that if we start the ACE inhibitors prophylactically, we help the heart muscle push against a slightly lower blood pressure. It preserves the muscle. It preserves your heart muscle and helps delay the onset of the cardiomyopathy by a few years. So in patients who have Duchenne muscular dystrophy or Becker's muscular dystrophy, we are at our center at Montefiore Hospital and a lot of other care centers across the globe have started to give these patients ACE inhibitors at the start of age 10. If you see dysfunction, cardiac dysfunction, some patients unfortunately show poor cardiac function even before the age of 10. And if that happens, obviously, that is our first line of management. We give them ACE inhibitors. You must have heard of medications like lisinopril, enalapril. Those are the medications that we start. Some centers are doing extensive MRIs, and if they start to see any evidence of myocardial fibrosis, so fibrosis meaning that the muscle of the heart is turning into a scar tissue and not so much muscle anymore. It is slowly getting weaker and it's turning into scar tissue. They start ACE inhibitors in these patients even before age 10 if needed. The second line of therapy is something called beta blockers. You might have heard of medications like atenolol, metoprolol, carvedilol. These are medications that are known as beta blockers. They have been around for decades. They are recommended by clinical care guidelines or by the AHA guidelines to be started in patients who have any evidence of systolic dysfunction, which means any sort of cardiac dysfunction. That means that the squeeze of the heart is compromised in some form. So, excuse me. So, beta blockers are often started in patients once we start to see that their heart function is getting worse. Patients who have heart failure, who have ejection fraction, so EF, you must have heard of that word in heart failure literature. EF, or ejection fraction, is basically how much your heart is squeezing, how much your left ventricle is squeezing. We look at a number in our head, 55%, which is considered normal. 55% means that when your heart is squeezing, 55% of the blood that is inside the heart is going out the body. And that is normal. Anything less means that it's abnormal. So when you have a lower EF, that just means that that less amount of blood is going to the body. So patients who have any sort of heart failure symptoms, which are truly because of heart failure and not skeletal muscle weakness, or who have mid-range ejection fraction, or patients who are now showing slowly that their heart function is declining very quickly. We're following them every year or every 6 months, and we're seeing that their heart function is slowly getting worse, and they're already on an ACE inhibitor. We add the second medication because they work together, they work in synergy, and we want to give them benefits from all angles and prevent their heart function to decline further. Patients who have persistent tachycardias, they can have sinus tachycardias, they can have symptomatic tachycardia, that their heart rate is so high all the time because of the entire muscle weakness that they have. We have started beta blockers in those patients as well who have just tachycardia because their heart is just weak. So that is our second line of therapy in medical management. The third line of therapy is called mineralocorticoid receptor antagonist, or spironolactone, aldactone. Those are the medications that we start. And there is very limited data that suggests that patients who get started on this therapy, especially patients in Duchenne muscular dystrophy, that it prevents in further decline of these patients who have poor heart function. Patients who have any sort of fibrosis, LGE basically stands for fibrosis, or muscle that is being converted into scar tissue. So the AHA guidelines say that anyone who has poor heart function, have any form of fibrosis, those patients should get started on mineralocorticoid in association with ACE inhibitors and beta blockers. So sometimes patients are on 3 medications, not because their heart function is very, very poor or they're in severe heart failure, but because we want to give them the benefit of all these medications that exist and prevent sudden decline in their heart function or prevent further decline in their heart function. I always tell my patients that sometimes if you have cardiac dysfunction with these medications, sometimes we don't see improvement because the heart muscle has already gotten that much weaker, and sometimes we cannot recover the heart muscle. And that is okay. What is very important in these patients is to prevent their further decline. If we can push out the decline in their heart function by a couple of years, give them more years of relatively normal or as close to normal heart function, that is an achievement in itself. So coming for follow-ups and hearing that the ejection fraction has not improved or has remained the same is not a failure. I think it's a victory, because every time that we see those patients and see that their heart function is still the same and has not declined further, in my head, that is still a victory. Talking just quickly about surgical management, what exists out there, we have something called a ventricular assist device. Basically, when your heart muscle is too weak to squeeze, too weak to pump, we have this machine. The latest one is called the HeartMate 3. And we have this machine that basically sucks the blood out of the heart as soon as it reaches the heart. And there's a rotary system that sits inside here and pumps it out to the rest of the body. There have now been a lot of cases where people have implanted a ventricular assist device in patients with neuromuscular diseases who are in bad heart failure. Some of these patients have eventually gotten to a heart transplant, and some patients have remained on the device for many, many years. It improves your quality of life. And there is a lot of research going on at this point in time, exploring this option in patients who have muscular dystrophy, as well as other neuromuscular disorders. So in 1993, people reported that individuals who had advanced neuromuscular disorder were not considered candidates given their multiple comorbidities. So patients, so providers or physicians were very hesitant to list patients with neuromuscular diseases for a heart transplant. They have comorbidities, like they have respiratory diseases, they have dysphagia, they have a sedentary level of activity. So traditionally, these patients are considered high risk because they don't get the benefit of the heart transplant because the other organs are compromised. However, hot off the press, this was just published this year, patients with muscular dystrophy is a viable option. Patients with muscular dystrophy were searched from the United Network of Organ Sharing, or the UNOS database. From 1987 to 2015, they found that there were 81 patients. Obviously, they formed a very, very low volume of the entire population. They formed only 0.2% of the recipients. However, because they study these patients, we are able to know that patients who have any sort of muscular dystrophy, but don't have ventilatory support, don't have other comorbidities, or patients who may have been on a ventricular assist device or VAD therapy prior to getting transplant, do as well as patients who patients who don't have muscular dystrophy. So this research was very, very important in that aspect, that it told us that if we select muscular dystrophy patients who need a heart transplant and they have no other comorbidities and they are just having poor quality of life because of their heart failure, we can do a heart transplant and their outcomes are not any worse than any other patients. So this is a very encouraging research that is coming out. So as many people have told you before, that it takes a village to take care of these patients. These patients need multidisciplinary management. They need inputs from many disciplines: neurology, pulmonology, orthopedics. I need inputs from all of these these providers before I can make decision on my patients. Neuromuscular disease is a spectrum of disease. No two patients are alike. Even if I have two patients with Duchenne muscular dystrophy, those two patients by themselves look very different, even though they may have the same gene problem, they may have the same similar phenotype, they both may be wheelchair bound, but they still, both of them are not exactly the same. So it is very important that we tailor therapy for each of these patients. Decisions need to be made as a team. This is something that I borrowed from the parent project, muscular dystrophy. And as you can see here, that they say that at the time of diagnosis, you have this individual with Duchenne muscular dystrophy that requires intensive care coordination, neurology, orthopedics, endocrinology, cardiology, GI, respiratory. We have a lot of providers, a lot of caregivers that take care of these families and help them transition across their life course. And I quickly took a screenshot of Dr. Delfiner's talk this morning, and you can see that MDA Care Center here at Montefiore has so many providers. To give you two quick examples, I have a 10-year-old patient who had Duchenne muscular dystrophy, who has a tachyarrhythmia called SVT, and also has depressed cardiac function. His EF is only 51%, which is not bad. But he's also obese, he's wheelchair bound, he's on BiPAP at night, he last saw pulmonology more than 1 year ago. So do I put him through a cardiac procedure to do an ablation to take care of this arrhythmia? Or do I just watch it? He doesn't feel the palpitations. This is a complex question with not an easy answer. And I was able to take inputs from pulmonology, from neurology, from other subspecialties to be able to make this decision for my patient. Secondly, I had a patient, 15-year-old, who had Becker's muscular dystrophy, who had heart failure. I wanted to list him. However, he was blood group O and had a long wait list time. So after talking with all his providers, I was able to give him a ventricular assist device. He was very stable. He got a heart transplant a few weeks later. However, since he had 2 open heart surgeries, one for a VAD and one for a heart transplant, there were concerns for pulmonary toilet or pulmonary status of this patient. There were concerns for deconditioning of this patient. So we needed extensive physical therapy. We wanted neurology involved. We wanted pulmonology involved to give the supportive care so that we can get this patient to a great outcome. So these are the reasons why you need an MDA center, you need a multidisciplinary approach, you need all the providers to be equally invested in the care of your patient. So in summary, there are marked cardiac dysfunction can exist without symptoms. Like I said, you can confuse those symptoms with just skeletal muscle weakness because the symptoms are very similar. So you need regular surveillance. Cardiac abnormalities are common in patients with neuromuscular disorders. They can be either cardiomyopathy, that is basically the function of the heart, the squeeze of the heart, or they can be conduction abnormalities, that is the wiring system of the heart. So you can be either in heart block or you can have abnormal rhythm problems like tachyarrhythmias. Clinical care guidelines or scientific statements exist for specific disease as guides to providers as well as parents, and I encourage parents to read through them for their own children. And it's very, very important to follow up at an MDA center with a multidisciplinary care team approach. It is very important to get very tailored approach to all the problems that exist for your particular patient. And I would like to once again thank Dr. Delfiner from the Children's Hospital of Montefiore to give me this opportunity and the MDA to organize this today. And I'm really grateful and I'm happy to take any questions at this point in time.
Wonderful. Thank you so much, Dr. Bansal. That was fantastic. And I was really happy to hear the information you shared about recently being allowed to go on the heart transplant list. I think that's a huge part for our population that may be in that position. I think we have some questions that are coming in. Just a reminder to everyone, if you have questions for Dr. Bansal, please go ahead and leverage the Q&A section on your screen, which should be down at the very bottom. We do have one question about where can I find a local MDA care center? And I think that's a really great question. I'm happy to go ahead and put a plug in, and following this Q&A section, I can go ahead and chat in a link. On MDA.org, you can go ahead and enter your zip code, and it will pop up with the nearest care centers, and it also provides their information and their scheduling number, so that you can go ahead and find a care center that's the closest to you. With that question, though, Dr. Bansal, I do think that, it brings up a really good question, too, and it just is, the cardiologist and the care center and that function and overall scope. I know at a lot of our centers, cardiology maybe isn't there on a day-to-day basis, but there is an opportunity to kind of connect in. Can you talk a little bit about how that works at Montefiore?
Right. So at Montefiore, I'm really blessed that Dr. Delfiner and me work just one floor apart. So she works on the 4th floor and I work on the 5th floor. So we are able to talk very frequently. I think even if a cardiologist is not available on site, it is very important for the neurologist to reach out, to be the advocate for their patient, to reach out to the cardiologist. A proactive approach, like I was talking about, is very important, that these patients come to attention either to the primary pediatricians or come to the attention of a neurologist first before they come to a cardiologist. So a proactive approach from the pediatricians in recognizing, referring to a neurologist, and a neurologist, after diagnosis is established, to recognize that they need a cardiac evaluation is very important. So even if they have no symptoms, I think a baseline or just a referral to a cardiologist to get their opinion as to how often to do the surveillance, what kind of surveillance to do, I think is very important. And I think that relationship between the providers is very important. Dr. Delfiner and me, we talk very frequently about our patients. We share concerns. We do a monthly meeting where we discuss all the patients that we are going to see in the coming 3 months, and we share concerns. So we do have a running list that is going on, and we discuss patients on a very regular basis. So I think that interaction is very, very invaluable.
Wonderful, wonderful. That's fantastic. We do have a couple additional questions that came in. One of the questions is, are there long-term follow-up that dictates how kids with pacemakers do and how often they need replacements?
Right. So pacemakers, it depends on what kind of pacemaker is being put in. A lot of the times, the way that the pacemaker in young adults, so I'm going to talk about teenagers, young adults, the way they put a battery that is put right under the skin, somewhere close to the shoulder. And then you have the leads that are sort of threaded in through the arteries that go into the heart. So it is very easy for us to replace the battery because it sits right here under the skin near the shoulder. A lot of the times these batteries, as the technology is advancing, we are able to squeeze more and more life out of these batteries. So I want to say that replacement is needed somewhere close to between 5 to 10 years, depending on what kind of battery life when the battery was put in and what kind of system it was. You are able to upgrade those systems very easily. So I would encourage that pacemakers should be followed by a pacemaker specialist. So we call them electrophysiologist or EP specialists. So I know that is also a subspecialty in cardiology and it sounds very complex, but your cardiologist should be able to talk to the EP specialist and talk to them about how often they should be followed up. Pacemakers in children that are placed in teenage years that are adult size do very well as adults, because they don't need to be replaced as common because the kids have sort of reached their puberty and have reached their height. Unfortunately, if a pacemaker is required very early on in a child that is still growing, as you can imagine, those leads don't grow when the babies grow. So slowly, as the babies start to grow, those leads start to have cracks or fractures. So they may need a little more often replacement, and that is very unfortunately dependent on like a case-to-case basis, and I'm unable to say how often those will need replacement.
Okay, that makes sense. Another question that came in is, I have myotonic dystrophy type 2, but I have a myriad of symptoms that are only usually seen in type 1. Recently, I was diagnosed with stage 1 heart block. Should I be starting any medications to help delay any deterioration?
Right. So unfortunately for conduction, so like I was telling you, there are two types of cardiac complications. One is the cardiomyopathy, where you have the muscle of the heart, the squeeze of the heart gets compromised, and the other is the electrical system. So unfortunately, there are no medications that would prevent progression of the problems in the electrical system. What I can say is that first degree heart block is still very subtle, and the only thing is that there's a delay in the talking of the upper and the lower chambers. So the upper chamber squeezes, the lower chamber should squeeze immediately after. But in a first degree heart block, imagine that there's a delay in the communication, but they are still talking. So I think that it is very good that the heart block is only first degree. But I do think that it becomes important to continue to follow up, because if slowly that heart block gets worse, unfortunately, the only therapy for complete heart block, if you are symptomatic, not every heart block needs to be treated with a pacemaker, but the only available treatment out there would be a pacemaker.
Okay, thank you. Another question that came in was around kind of what you shared around those medical management medications. Are those meant to be lifelong treatments?
Yeah, unfortunately, since we are trying to delay the progression of heart dysfunction, we're trying to delay as much as possible. It is unfortunately becomes important that we take these medications every day and for as long as we can. Obviously, every medication has side effects. So if your cardiologist starts to see that your kidney numbers are starting to go up, or that your potassium electrolytes are all over the place, they may choose to stop a medication because of those, or change them. And those would be done in consultation with the cardiologist. But yes, they do remain, we do keep them for life, unless there are some complications.
Yep. Okay. Sounds good. And the last question that I see in here, and Dr. Bansal, this may pertain to you, or it may pertain more to Dr. Delfiner as well. And it's something we've talked a little bit about throughout the day, but haven't had a chance to just dive in. And that's just around kind of COVID and the impact COVID's having kind of in our world. And this person talks about how COVID scares him, and they live with respiratory failure now. Any guidance to getting in to be seen at a center in light of COVID? And I don't know, Dr. Bansal, do you want to talk about kind of what you're doing?
I can say what I say to all my patients. I think it is very, very important that you find out what kind of systems are in place at the care center that you want to go to. So I will give you examples at Montefiore. What we do, we limit the number of people that accompany a patient. For a child, we let only one parent accompany the patient. This limits the exposure in the waiting room. This limits the exposure to the provider. The providers are all wearing all gears. So we're supposed to be wearing goggles, face shield, a mask, gloves. So find out if your provider is appropriately wearing PPE and enough PPE exists for them. We are taking very good precautions of rooming patients very quickly, so they are not sitting in waiting rooms for a long period of time. Any patient who enters our building has their temperature taken, and every person, not patient, every person is supposed to be masked at all times. So there's universal masking that happens at Montefiore. In addition, our secretaries are very good about doing a COVID screening for all families that are coming to the clinic. So any patient who has had, their caregivers or the patient themselves have had any history of any symptoms in the last 7 days, we ask them to kind of defer their appointment, or if there's any concerns, we defer the appointment. So the onus is on the hospital or the care center to provide a service where it is safe for patients to be able to come in without the stress of am I going to get COVID? Because I think it's very important for patients and families to get the care that they need, and the onus becomes on the provider and the hospital, because the last thing you want is for families to not get the care and unfortunately have complications, or unfortunately sometimes if death, because of not getting appropriate care. So I think it will help if they want to call their care center and find out what are the practices that they are doing to provide safety to the families and the patients that are coming in.
Perfect. Thank you very much. And I do think, MDA, what we've been seeing with the care centers, it's just amazing how quickly people are able to adapt and adjust. So many of the providers now do offer the telehealth and have put, steps in place in the institutions, as you were talking about, to ensure that patients and families can come and be seen in a safe and effective manner. So it's fantastic for you to share that. And I do think most of the institutions out there have implemented these types of precautions as well.
Absolutely.
Wonderful. All right. Well, Dr. Bansal, thank you so much for your time today and for sharing all of that wonderful information.
Thank you so much for having me. It was a real pleasure. Thank you.
Wonderful. Well, with that, this does conclude our seminar for today. Just in closing, I again would like to thank all of our wonderful presenters for their time and their effort that they spent putting these presentations in today. It's not just that they show up and give their presentation. They work with us on it. They work with Dr. Delfiner on it. We do practice to get ready. So we really just appreciate the time and effort and the information that was shared today. And again, I'd like to thank especially Dr. Delfiner. She's been instrumental in helping put this event together today and providing input on speakers and getting our wonderful list of speakers together today. So before we wrap up, I just would like to ask Dr. Delfiner, is there anything, any last closing words you'd like to share with the group?
Oh, thank you so much for giving us this opportunity today. Any chance that we as clinicians, and I know I'm speaking on behalf of all doctors who provide care to muscle patients, any chance we get to engage with families outside of the office is an opportunity both for us to get to understand your needs and your interests and your goals better, and perhaps to build bridges and advocacy so that we can help advance neuromuscular care in the clinical space in general. Everything about the MDA is hope these days. Things are changing, treatments are coming. We have our first clinically available gene therapy. We have exon skipping therapies. We have new steroid-sparing agents for some of the autoimmune diseases. Please, please, please stay connected with the MDA. Keep coming to these events because the future is bright. I have nothing but hope as long as we keep working together, keep communicating together, and continuing to coordinate care in the best way possible.
I think you said that beautifully, Dr. Delfiner, and you're spot on. It does take all of us working together to be able to get there, and we are seeing some amazing progress and want to continue to see that progress. So thank you again for everything and all your work and effort in helping put this seminar together. Additionally, as you'll see on the screen, I would like to thank again our supporters. Without their support, our programming, our educational programming would not be possible. So I would like to say special thanks again to Biogen, Numotion Foundation, and Genentech for supporting not only this program, but supporting all of our seminars through the year, through 2020. And thank you again to you for joining us today. We know everyone has a lot happening, and we really appreciate you taking time out of your day to join us. We really do hope you found the information here helpful and informative. If you do have any questions after the seminar or about any of our Engage community education programs, please visit us at mda.org/engage. or email us at the email address on this screen, and we'd be happy to talk with you offline as well. And finally, I just want to remind you that this was recorded today, the seminar, and we will be posting it on mda.org in a few weeks. We'll share with everyone when that's available. And then my last plug is I will be sending out an email with a brief survey about what and want to be able to collect your thoughts on this seminar. Your feedback's very important to us. I scour over all of this feedback every year when we're working on our events and we're planning out kind of what kind of topics we want. So please be on a lookout for an email from me later today. It will come from the mdaengage@mdausa.org email address. I also placed on your screen, if it's just as easy, a QR code that if you do have a smart device right now and want to access the survey right now, go ahead and just open your camera and hold it near the code. And then you should get a pop-up on the top of your smart device and click on that and it should take you directly to the survey. So just another way to get to that survey. All right, again, thank you all so much for joining, and we look forward to you joining us at other Engage events in the future. I hope everyone stays well and safe and has a great rest of your day. Thank you for attending.